name is Celine Leduc, and I am a student nurse at the University of Michigan. My patient, initials ST, is a patient at the Beach Unit at Heartland Healthcare Center. Patient is a friendly 92-year-old African American female who never married or partnered. Her previous occupation was a waitress and bartender in Detroit after moving from Mississippi in her late teens. Her usual source of medical care is at St. Joseph Mercy Hospital in Ypsilanti, and her primary physician is also based in Ypsilanti. Patient's chief complaint is her pain status post-cholecystectomy. Her pain began after her surgery in March 2015. Her pain is in the area of the percutaneous drain in her right upper quadrant, described as sore and itching. She rated her discomfort on a 5 on a scale of 0 to 10, with 10 being the worst. Nothing makes the pain worse, and only scratching the area relieves her discomfort. She reports no action for coping, no impact on her activities of daily living, and no difference in her mood or emotions due to her pain. Patient presents as a poor historian, therefore most of her health history was extracted from her paper file. Her childhood illnesses included an appendectomy as a teenager. She has a history of type 2 diabetes, depression, hypertension, hyperlipidemia, macular degeneration, insomnia, debility, osteoporosis, osteoarthritis, COPD, mild dementia, diabetic retinopathy, and a chronic cholecystectomy tube. Family history includes breast cancer, COPD, heart disease, hypertension, stroke, alcohol abuse, and high cholesterol in siblings. No record was found for her parents or other relatives. Patient was unable to recall family history. Patient's immunizations are up to date. She is allergic to codeine sulfate, resulting in GI distress, and lisinopril, resulting in hyperkalemia. Previous hospitalizations include cataract surgery in 2008, facial fracture in February 2014, and most recently for her cholecystectomy in March 2015. Patient denies any current drinking or use of illicit drugs. Patient smoked for 5 years when she was younger and denies any smoking currently. Patient has daily exercise including her arms and legs, and she eats 3 meals a day provided by Heartland. Her sleeping pattern is irregular, stating she sleeps the best they let me, due to frequent waking by staff for medicine administration at 2 a.m. and 6:30 a.m. and again for breakfast at 9:30 a.m. Patient drinks black coffee 2 times a day. In terms of safety devices, patient uses a walker for ambulating and reading glasses to see closely. Patient is one of 9 siblings with 3 brothers and 5 sisters. She lives with her youngest sister when not in a medical facility. Patient had 2 sons who are now deceased. She has 1 grandson in college. She reports a good relationship with her sister and they visit frequently. She reports nothing is stressful to her at the time. Possible environmental hazards could include secondhand smoke during her years as a bartender. Patient identifies self as a holist and attends religious service on Sundays. Patient's level of education includes a high school diploma. Patient reports routinely visiting her physician. Patient's vital signs are heart rate of 80 beats per minute, a respiratory rate of 18 breaths per minute, blood pressure of 152/84, and an oral temperature of 97.2 degrees Fahrenheit. The first physical exam was abdominal. Inspection revealed no abnormalities in color, contour, umbilicus, symmetry, movement, or surface motion. No bulging or masses were visible. The right upper quadrant contained a percutaneous drain from patient's cholecystectomy. Otherwise, no lesions or scars were visible. Auscultation of the 4 quadrants revealed consistent bowel sounds every 5 seconds, and no bruits were auscultated for vascular sounds. No masses or pain were palpated in the 4 quadrants other than pain in the right lower quadrant. No palpable aortic pulse. For peritoneal irritation resulted negatively, including tests for iliopsoas, obturator, and rebound tenderness tests. Review of systems for the abdomen revealed diminished appetite beginning 1 year ago. Patient describes an intolerance of eggs her entire life, resulting in vomiting. She reports vomiting at least 1 time a week, usually after drinking juice or eating strawberries. Patient's last bowel movement was in the morning, no report of diarrhea, and she complains of frequent constipation. Her bowel movement has changed from loose to formed and color has changed to black. Patient denies issues with suprapubic pain, dysuria, urgency, hesitancy, nocturia, hematuria, and kidney or flank pain. Patient confirms polyuria approximately 6 times a day and incontinence approximately 2 times a month. Patient reports no dysphagia, no abdominal pain, no fever or chills, no bloody stool, no past abdominal history other than her cholecystectomy, and no reported family history of abdominal issues. She has no current alcohol, drug, or cigarette use. Her 24-hour nutritional recall reveals an appetite of mashed potatoes, salad, beef, ham, fish, green beans, peas, milk, and no fruit, approximately 3 meals a day. Patient reports weight gain in the past month from 142 pounds to 146 pounds. The second physical exam was of the patient's neurological system. The patient scored a 24 out of 30 on the mini mental state exam, having difficulty with orientation, long-term memory, and judgment. Patient was unable to perform assessments for gross motor and balance testing, including the Romberg test. Patient's upper extremity fine motor function was intact. Patient denied ability to perform lower extremity fine motor functioning. Patient's light and painful touch sensation was intact, along with cortical and discriminatory sensation. Vibratory sensation was not available for assessment. Pathological reflexes, including Babinski and ankylosing, had negative results. Patient was assessed for review of the neurological system. Patient denies headaches, head injury, seizures or convulsions, tremors, difficulty swallowing, personal and family history of neurological issues, and alcohol or recreational drug use. Patient describes one incident of vertigo 2 weeks ago upon standing in the bathroom with the floor falling away from her, but issue resolved itself in a timely manner upon resting. Patient describes change in vision when reading, now uses reading glasses. She describes a change in hearing that began years ago and has difficulty understanding others. Hearing loss in both ears, both high and low pitch sounds, and no use of hearing aids. Patient describes loss of smell beginning 2 years ago. Patient denies changes in touch and taste. Patient describes a weakness in the whole body beginning 6 months ago with no treatment. Patient describes numbness but describes tingling in her foot and a pain in both legs that shoots down her leg like lightning, giving the pain an 8 out of 10 on a scale of 0 to 10, with 10 being the worst. Patient also describes difficulty with speaking beginning 1 year ago, including issues with pronunciations and speech. In addition to the assessment of the abdominal and neurological systems, it is important to complete an HENT assessment and musculoskeletal assessment. According to Kwan et al. In the Iranian Journal of Public Health, improving the health-related quality of life of the elderly requires prevention of dual sensory impairment through regular screenings and continuous management of vision and hearing impairment. This evidence shows the importance of assessing head, eyes, ears, nose, and throat system for my patient, particularly since she is elderly and has vision, smelling, and hearing loss. Additionally, a study in the International Journal of Rheumatic Diseases by Mustafa et al. Found that musculoskeletal hand disorders were prevalent in type 2 diabetes patients. Limited joint mobility was the most frequently seen complication. This gives prevalence to assessing my patient's musculoskeletal system, since her diagnosis of type 2 diabetes puts her at risk for impaired mobility. This concludes my patient's information. Thank you.